My name is Brooke Phillips, a Marketing Manager for Shield Healthcare, and I'd like to welcome you to our webinar today on screening strategies to reduce fall risk. Before we begin, just a few housekeeping items. Attendees will be in listen-only mode. If you have a question, please type it in the question box on the right-hand side of your screen. A PDF of the presentation slides is also available as a handout that you can download right from the webinar. If you registered as a healthcare professional and would like to receive CE credit, look for an email from Capital Nursing Education containing your CE certificate within 5 to 7 business days. If you're watching this presentation as part of a group, please download the group CE handouts from the webinar panel in order for everyone in your group to qualify for CE credit. If you miss any portion of this presentation or would like to share it with a colleague, the webinar is being recorded and will be available on shieldhealthcare.com/webinars by the end of the week. Now I'm delighted to introduce Kelly Sparks as our presenter today from Capital Nursing Education. Beg your pardon on that. Kelly Sparks, RN, BSN, CWOCN, CFCN, has been a CWOCN for more than 25 years and a nurse for more than 30. She's worked in wound, ostomy, and continence care for most of her career. Kelly has been on the board of directors of the Pacific Coast region several times in the past and on multiple projects for the WOCN certification board. She's active with the local Sacramento WOC nurse group where she serves as secretary. She's recently retired from Dignity Health, but continues with her private practice. Kelly has been a speaker for many different conferences and classes. She enjoys speaking for Shield webinars and working with Capital Nursing Education to help promote education necessary for the care of patients. At this time, I'd like to pass the presentation over to Kelly. Kelly, it's all yours.
Thank you, Brooke. Good morning, everybody. We're going to talk today about how to screen elder patients for reduction of fall risk. And this is a very, very important part of the aging process as our patients all are getting older and older. So the topics that we're going to cover on this, there's 5 main topics. First, we're going to look at the magnitude of the problem because this is a huge problem. The second thing that we're going to do is look at the risk factors related to falls, what makes them fall, and how we can help with different ways to help them to keep from falling. And then investigate different risk assessment tools, and we'll go over a couple of those tools. You may find one that works well for you. And learn the 3 key risk factors for falling. And we'll go over some community and educational resources as well. So as we're looking at this, the threat to the elderly's quality of life is a huge factor with falls. When they fall, what ends up happening is there's about a 20 to 39% of them who will limit their activities later. In other words, if they fall once, they're going to be so afraid that they're not going to move as much. And that causes them to decondition even more. And then that causes them to be even weaker and then to fall more. So there are intrinsic and extrinsic factors that some of those are modifiable. So there are falls that are completely preventable. So we'll be looking at all of those. You know, when I was doing this, putting this presentation together, I came across this CDC's web-based injury statistics query and reporting system. Very, very interesting that the number of the unintentional fall deaths, all races, both sexes, 60 to 85 years old, in 1999 to 2017 was 393,375. And compared that to the violence-related injury deaths and the suicide deaths, which I'm very sad to see were almost the same, unintentional fall deaths were so much greater, and most of those are preventable. So I just found this very interesting, the CDC's WISCARS, however you say it. It was very interesting to go over that. So like I said, there's extrinsic and intrinsic, and we're going to go over both of those. So between what they can take care of and what they can't take care of. So we'll look at those in detail. I'm not going to read them to you now. So let's go ahead with the extrinsic. Home and neighborhood features. When you look at prevention of falls. You want to look at things like the slippery floors, the throw rugs, steps in and out of the house or in and out of a store. Loose cords or mats are a huge thing if people walk along and all of a sudden trip on those. Poor lighting, and we'll go over why poor lighting is a definite a definite thing that causes falling in elderly people. Obstacles in the pathways or on the stairs. And then outside, if they're going out into the community, there's things as sloped yards, the crowded sidewalks, heavy doors, uneven sidewalks. They can trip on those, cracks in the sidewalks, and then curbs are a huge thing that a lot of people fall over the curb. Even where there's the yellow little bumpy spot for handicapped people, even that, there's curbs right up to it. Sometimes they aren't beveled down and they can trip on there. There is, you're going to hear me talk about my neighbor, okay? I have a neighbor named Bob, and he's 88 years old. And throughout the program, I'll probably refer to him because he, just like a lot of people, refuses to do things such as the community fall programs, or he refuses physical therapy or occupational therapy. And basically, he's setting himself up to become one of the statistics that fall. So he could become injured and hospitalized, and that's going to cause further deconditioning. And so then he falls easier because of weakness. So I'm going to refer to him every once in a while. I just wanted you to know that. There are good community fall prevention programs where they do assist with exercises and things like that. So the assistive devices that we all can look at for helping our elderly are very important. Encouraging independence, however, I've seen some people get a little too independent and don't want to accept the help from other people. Physical therapy is a wonderful way to get the exercises so that their core strength is better, so they don't fall as much, and possibly include an occupational therapist as well. And again, this little algorithm down below, injury due to falls causes them to go to the hospital. They become immobile in the hospital, and that further deconditions them, and then they're going to fall more regularly. So it's a vicious cycle, and the only way to break that is exercise and strengthen their core so that they don't fall. You know, slippers are my biggest pet peeve. A lot of elderly people cannot put on their socks. So what they do is put on those slip-on slippers, and they're called slippers for a reason, and it's because they make them slip. Slippers are horrible for people to wear. There are some people who just wear slippers that they can step into because they can't reach their feet to put their shoes on, and I call them hip breakers. Because a lot of the patients I've seen in the past, especially little old ladies, end up slipping because that slipper comes off, and then they fall, and then they break a hip. So we just call them hip breakers. They don't have a strap on the back. That's the danger, is there's no strap on the back. So it's very important for them to have very well-fitting shoes and to wear socks so they don't get blisters and problems with their feet. Wide toe shoes, of course, are a lot better. I've also seen some elderly women who really like to wear a little heel. Low heels are fine, but when they put on those high heels that they're used to wearing when they were younger, those are very, very dangerous for them. And also, not to walk around on slippery floors without shoes on. A lot of people don't realize that one little slip on that hardwood floor and you're down. It can really be detrimental to their life in the long run. There are so many assistive devices out there that can really be helpful. A lot of the falls, the majority of the falls in elderly are in the bathroom for several reasons. We'll go over those. But first of all, grab bars are very necessary, and they need to be where the patient or the person can grab them to keep from falling, getting in and out of the shower, or even right by the toilet, they could use them. Non-slip mats for bathtub or shower, that's very important. There's many different types of sock donners out there, and they do work very, very well. A lot of times when people have hip surgery, they end up having to use those for a while, and then it kind of grows on them. They kind of like that. Raised toilet seats, really important for people to be able to get up. And then again, in the shower, that shower chair is extremely important so they can actually sit while they're taking their shower. Assistive devices such as the steady furniture. If you have a rolling chair in a home with an elderly person, that is extremely dangerous for them to do. They really don't quite get that chair is going to roll right out from under them. The other reason we need steady furniture is because a lot of elderly people will use the furniture to actually hold on to and to walk, from one place to the other. You don't want them to have the furniture moving out from under them. Walking aids, tripods, canes, and walkers. We use those with elderly, and I'm telling you, it is such a help. I recently went on a hike with my son for my birthday, and he brought the walking stick. And I said, oh, come on, I'm not that old. I don't need those. Well, yes, I am that old, and I did need those, and it really helps. So any type of walking aid is very, very helpful for these people. Chair raisers, wonderful, or riser, however you want to say it. You put it underneath the chair, and it just raises it up enough to where the person can get in and out of it easier. There's seat lifts, there's reaching aids, and I've seen Bob go out in his driveway. It's a little scary, but he takes his little reaching aid and he walks down the driveway and he picks up his newspaper every morning with his little reaching aid. And it's kind of cute, but it's a little scary because he teeters when he's doing it. So it's a little difficult for him, but reaching aids are great. I use reaching aids any chance I get at home because I have high cupboards. I can't get in them, so I'm already used to those in my young age, right? Alarm systems for help are extremely useful. They have many different kinds. You've seen the commercials, help I've fallen and I can't get up and all that. But what I have found is that there's different companies that do it different ways. I like the one where if a person were to, they wear the necklace or the bracelet with the push button, if they push the button and they say they fell, push the button, the company will actually try to call them. And if they don't answer, then the company will call the next number that they have on their list, which would be, say, for instance, a daughter or whatever, whoever's closer to them. And then if they don't respond, then they will call 911 and have, the fire department or somebody come to the house. And the cool thing about it is it used to be when the firemen come to the house, they would break down the door. I mean, that's just what they have to do to get inside if a person can't get up and come and unlock the door. And so they give a little lockbox for the door, and the sheriff's department, the local sheriff's department, and everybody is given a code to get into that lockbox to get the key so they don't have to break the door. I thought that was very interesting and very well planned. But the alarm systems are extremely important for elderly if they can remember to push them. Alcohol, this is real interesting too that I didn't know. Researchers compared moderate drinkers with lifelong alcohol abstainers, and those who drank in moderation were 21% less likely to fall. Go figure. And they were 33% less likely to have a fall needing medical help, and they were 42% less likely to have two or more falls. Very interesting. I don't get it, but okay, we have no problem with that. I know that Bob has a couple of drinks a day, and he seems fine and hasn't fallen, so there must be something to that. And abstaining from alcohol appears to be a risk factor for falls among older adults. So, consequently, we can reduce that risk by drinking in moderation. I guess that's what the studies show. So we need to let them drink in moderation. That's perfect. Okay, we're going to look at some intrinsic risk factors that come up. Behaviors and choices. This is a really difficult one because, like I said, some people they just totally deny that they would ever fall. Oh, not me, I've never fallen, so therefore I'm never going to fall. Dementia altering cognitive ability to see the importance is usually why they think that it will never happen to them. Personal experience, if they have a history of falls, then that kind of makes it so that yes, they're probably going to fall again. I know with Bob, and I've talked to him about it, he feels that he's weak if he asks for help. I'm a strong, big man, and I don't need any help, and I can do this myself, and no, I don't need PT, no, I don't need OT. And exercises? Heck no. Can't get him to do any exercises whatsoever. So it's really, really difficult when people get to that, especially that little bit of dementia that tends to ruin any chance of them understanding that it can happen to them. So a review of the literature actually reviews that many healthcare providers believe falls to be a symptom of a disease process or a drug side effect unless these diagnoses are ruled out. So there's comorbid diseases such as osteoporosis and age-related physiological changes that happen. There's slower reflexes, there's changes in vision and gait, and often they're associated with falls in the elderly. So with the vision, what happens is they reduce papillary response to light variation. Like I said, going from a light room to a dark room or a dark room to a light room, there's that thickening and loss of elasticity of the lens, so they can't adjust fast enough to the difference in light. And then, of course, with gait, the decreased step height, decreased proprioception. If they have any type of neuropathy or anything going on in their feet, they can't tell where their feet are when they're walking. And they wouldn't notice sometimes if they stepped on a pebble or, a rock big enough to cause a problem. That's why the sidewalks and everything are so important to keep from having any places they could trip. That step height, I can see it with Bob when he walks. It's kind of like continually dragging that foot when he makes steps. And again, they have no clue that that's happening. Balance, they have increased postural sway. So when they're walking, they're going to be swaying, but yet they don't have the core strength to keep from falling when they do that swaying. So they have slowed riding reflexes. In other words, if they start to fall, it takes them longer to correct that if they have the muscle strength to do it. Incontinence, those of you that have seen my lecturing know that I am one with incontinence on my mind all the time for patients, and one of them is they try to hurry. They fall as they're trying to hurry to the bathroom, gotta go, right? And then the other thing is when they fail to get there in time, there's going to be a little puddle on the floor, and boom, they're going to slip. Another thing is just a little bit of leakage makes them want to hurry fast. So it's really a problem with people with incontinence. Trying to get out of bed fast enough and get to the bathroom is a huge problem, and then you're in the dark. So there you go. You got your vision problem, your gait problem, your balance problem, and incontinence all at one, and it can be very detrimental to these people. Chronic illnesses, anybody with any of these illnesses, it does decrease their ability to keep upright and not fall. Arthritis, of course, there's the pain. Depression, we'll go over a little more later. Diabetes, they may have that neuropathy where they just can't tell whether they're stepping on their feet or not. Stroke, where they might be dragging one leg trying to walk, or they're off balance. With asthma, it's difficult because they walk a little and then they have to stand or sit down, walk a little, stand or sit down, and that can be detrimental too. Cancer, angina, and chronic kidney disease. These are all chronic illnesses that come into play with in regards to falls. So medications very much increase the risk of falls, some of these. Antidepressants, antipsychotics, all of those will definitely have a play in their balance and their, look at their antihypertensives. If they take too many or they actually are on too high of a dose, then they're going to get, a little bit of postural hypertension and possibly fall because of that. Diuretics, they're going to pee more, right? That's going to make them have to go to the bathroom more. And then you get into that whole incontinence thing or that rushing to the bathroom because, don't you know, I took my diuretic and I got to get there fast or it's not going to, I'm going to leak all over the place. So these medications really do have an effect on their risk. Cognitive defects, very interesting that, the relationship between falls and depression may be partially explained by the poor health status and impairments in sensorimotor performance. The use of multiple medications, of course, has consistently been found to be associated with the falls in cognitively impaired older people. And it's also been shown to be a case in individuals with dementia. So this may be a reflection of the underlying pathologies and associated frailty. And, alternatively, the direct effects of certain drugs that they have to take for these things. And Lewy body dementia, that's a disease where it's associated with abnormal deposits of protein called alpha-synuclein, synuclein in the brain. And these deposits called Lewy bodies, they do affect the chemicals in the brain whose changes in turn can lead to problems with thinking and movement and behavior and mood. This is what Robin Williams had before he committed suicide and didn't want to live with that. Lewy body dementia and dementia related to Parkinson's disease have been associated with higher fall rates. These are the four things that actually are huge cognitive defects. The Lewy body dementia and dementia related to Parkinson's, they definitely have been associated to higher fall risk. Injury falls are more common with the moderately impaired dementia. So, and then repeat falls are common with the severe dementia patients. So these are definitely increase that fall risk considerably. Acute illnesses, fever, confusion from UTI. I've seen patients with such bad confusion from UTI that, you would think they totally went out in left field and give them some antibiotics, get rid of that, and they're pretty good after that. Dizziness, like I said, there's a lot of different things that can cause dizziness, and again, multiple medications. So how do the elderly feel about falls? I can tell you through experience that they usually underestimate their risk. Like I said, I have never fallen, therefore I'm never going to fall. They attribute falls, if you ask them, they will blame it on the environment. They will blame it on rushing. They will blame it on being distracted, and rarely is it intrinsic or personal health factors. It's usually the environment. Oh, that chair was in the way. Oh, that rug flipped up, whatever. Few use preventative strategies such as balance exercises and things like that because that's just how they feel. They want to be strong still, and they need encouragement to adopt prevention strategies to reduce their chances of falling, which then leads to, again, that functional decline and injury or death. So they don't see it how we see it. So we have to work with how they feel about it and try to help them to see how important it is. There are certain requirements and incentives for the primary care physician. A fall risk assessment is required as a part of the Welcome to Medicare examination. PCPs can receive reimbursement for fall risk assessment through the Medicare annual wellness visit, which actually is a good incentive for them to actually do it. You know, I have helped with Bob a lot, and I have taken him to appointments, and I was really impressed with a new physician that he just got who actually said, this is your Welcome to Medicare examination, even though he's been with Medicare for a long time. But she took the time, and I was so impressed. She took the time to do the entire assessment, and I was really, really impressed that she did that because I have never seen that before. They can receive incentive payments for assessing and managing the fall risk through voluntary participation in that physician quality reporting system, which we'll talk about in a little bit as well. So kudos to that doctor. Risk assessments, tools for fall prevention. We're going to look at several different kinds here, and I'm going to kind of go through them because some people, you know, may not have recognized or may not have seen each one of these. So we'll look at these in a little bit of detail. Johns Hopkins fall risk assessment. Okay, if the patient has any of the following, check the box and apply fall risk interventions as indicated. And then, for instance, the high fall risk, do they have a history of more than one fall within 6 months before the admission? And you may have to ask the family as well, because a lot of times the elderly are going to deny that they've had any problems. So, and has the patient experienced a fall during this hospitalization? That's important. Are they there because of a fall? Are they deemed high risk for protocol, like seizure precautions or anything like that? That would be the high risk categories if you check any one of those. The low fall risk, implement low fall risk interventions per protocol. So completely paralyzed or completely immobilized. They're probably not going to be falling out of bed. So they would be low risk. And then don't continue with this risk score calculation if any of those are checked. So if you need to check any one of those, you're done, okay? If you don't check those, then you're going to look at some other things and add up the points. So looking at age, you're going to select one thing of those choices that you see. Are they 60 to 69, 70 to 79, greater or equal to 80, and then put the points to the side so that you can add them up. Fall history, single select, of course there's only one there. One fall within 6 months before admission. That's going to give them 5 points. Elimination, bowel, and urine, you're going to check one of those. Are they incontinent? Do they have urgency or frequency, which can be a huge problem? And incontinence, that gives them an extra 2 points. So you add up those points accordingly. Medication includes PCA, opiates, anticonvulsants, antihypertensives, diuretics, hypnotics, laxatives, sedatives, psychotropics. So you're going to look at those. If they are on one high fall risk drug, 3 points. On two, it's going to be 5 points. If they were sedated within the last 24 hours, they're going to be 7 points. And then the patient care equipment, any equipment that tethers the patient. Do they have an IV? Do they have a chest tube, indwelling catheter, SCD? Anything that you either have to take off or take with them when they get up. 1 is 1 point, 2 is 2 points, and 3 or more is going to be 3 points. So again, you're adding these up. Mobility. This is a multi-select also. You're going to choose all that apply and add the points together. Do they require assistance or supervision for mobility, transfer, or ambulation? That's going to be your 2 points. Do they have an unsteady gait? That will be 2 points. Visual or auditory impairment affecting mobility. another 2 points. Cognition, you're going to look, this is a multi-select. You're going to look at that very carefully to see altered awareness of immediate physical environment, 1 point. Impulsive, 2 points. Lack of understanding of one's physical and cognitive limitations, which is huge in a lot of these people. So then you're going to total these up, the sum of all the points per category. And what that's going to tell you is the scoring. If they have 6 to 13 total points, they're moderate fall risk. If there's more than 13 total points, then they're high fall risk. And then you implement your interventions accordingly, according to your hospital or wherever you are, their protocols. So that's the Johns Hopkins, and a lot of us have seen that and have used it. I was really impressed with this STEADI study, which is Stopping Elderly Accidents, Deaths, and Injuries. This is put out by the CDC as well, and it's an evaluation guide for older adult clinical fall prevention programs. Great program, and I kind of wish I had seen this years ago because it really is a great program. And I put the website here so that you could get right on it real easily because it's extremely user-friendly. So the CDC has developed this algorithm, and I'm going to go over it a little bit. It details each step of the screening and assessment and guides interventions based on each individual's level of risk. So I'm going to start at the top. We're going to go down the left side first, and then we'll go back up and look at the other ones. So there are wonderful brochures that come with this study program, and one of them is Stay Independent brochure. And there is a little test in there that they need to do. And once they do it, then you're going to go to the second screen or the second square, which is to screen for falls and or fall risk. If the patient scores more than 4 on the Stay Independent brochure or answers yes to any of the key questions, like for instance, fell in the past year, if yes, how many times and were you injured, or feels unsteady when standing or walking, or worries about falling. Any of those, let's say we're going to go straight down here. That's the screen part. Stay independent score of more than 4 or yes to any key questions. You're going to go down to evaluate the gait and the strength and balance. There are 3 things that they recommend here, and we'll go over those in a little bit. But one is timed up and go, and one is 30-second chair. 30-second chair stand, and one is the 4-stage balance test. So then we're going to look at gait, strength, or balance problems. If they had more than 2 falls, we're going to go on down to conduct a multifactorial risk assessment, which is reviewing that brochure, their falls history, physical exam, including postural dizziness, postural hypertension, medication review, cognitive screen, feet and footwear, and use of mobility aids and visual acuity checks. So that's all down in the manage box. Now let's go back up here to assessing their gait, strength, or balance problems in the middle, that gray box. Let's say they had 1 fall and they had an injury. You're going to go right down to that multifactorial risk assessment. That's very important. Then if they had no injury, we can take them over to the moderate risk, which is over to the right. Now, going back up, I want to go back up to the very first screening, and let's say they scored less than 4, and you know what I could be doing, and I think I will. I think you can see my mouse. We're up here. Score less than 4 and no to these key questions. Then we can call them low risk, and we can educate the patient. We can start them on vitamin D and calcium. We can refer them for strength and balancing exercises, use the community exercise or fall prevention program. So you can see that going down this way, when you evaluate the strength and balance and do these little tests, if they have no strength or balance problems, you're going to call them low risk. However, you might consider doing this multifactorial risk assessment. And, you know, when you come down and they've had 2 falls and an injury, you're going to go to high risk, and then high risk follow-up. Moderate risk, if they've had no falls or 1 fall. Moderate risk is educating them, modifying their medications, again, vitamin D and calcium, and refer to PT or the community program. And then when you do a high-risk follow-up, that's in 30 days. You review their care plan, you assess and encourage fall risk reduction behaviors, and discuss and address barriers to adherence. Transition to maintenance exercise program when the patient's ready. So I know that's a lot to read and a lot to follow, but if you sit and look at this for a little bit, you will see that it's a very, very useful algorithm. So it's based on American Geriatric Society and the British Geriatric Society guidelines. And there is input from practicing clinicians, which is great. It's designed to help healthcare providers integrate falls assessment and management into their practice. It's just a wonderful program. So with this, number one, it does highlight that even individuals at low risk can benefit from this program, from the primary prevention approach. And it helps with education about fall risk, strength and balance exercises, vitamin D supplementation. It's a wonderful, I just can't tell you how much I like this program after I was looking at it. Here's the brochures that they have through the STEADY program. And you can see there's even one for family caregivers, and checking for safety, what you can do to prevent falls, postural hypertension, and staying independent. Great, great, great program. Okay, the Morse fall scale. This is very, very common. It's rapid, simple. A lot of nurses know this one, and a large majority of nurses rate the scale as quick and easy to use. There's just 6 variables, quick and easy to score, and it has shown to have predictive validity and inter-rater reliability. It's used widely in acute care settings, both in the hospital and in the long-term care setting. So we'll go over this real quick because I'm sure most of you have seen it. There's a scoring sheet here, history of falling immediate or within 3 months, yes or no. And again, it's points you're going to put off to the side. Secondary diagnosis, the ambulatory aids. If they're bed rest with nurse assist, then they're going to be a 0. Crutches, cane, or walkers, 15. And using furniture to hold on to is the biggest, that's 30. If they have an IV or a saline lock or heparin lock, then it's going to be yes or no to that answer. Their gait with transferring, normal, bed rest, immobile. That's going to be 0. If they're weak, it's 10. If they're impaired, it's going to be 20. And then, of course, their mental status, you need to know if they're oriented to their own ability or if they forget their limitations. And we're going to add those up for the Morse. The items in the scale are scored as follows. History of falling, I went over this before. If they've fallen during the present hospital admission, or there's been an immediate history of physiological falls, such as from seizures or impaired gait prior to admission. And then, of course, if they haven't fallen, it's 0. So if this patient has fallen for the first time, then it's immediately a 25. Secondary diagnosis. More than one medical diagnosis is listed on the patient's chart, or not more than one medical diagnosis. So it's either 15 or 0. Ambulatory aids, if they are walking without a walker aid, even if assisted by the nurse, or if they use a wheelchair, is on bed rest, doesn't get out of bed at all, that would be a 0. Scored as 15 if they use crutches or canes, and scored as 30 if they ambulate clutching onto furniture. Normal gait scores 0. Weak gait, of course, is 10, and then impaired gait is 20. So they may have difficulty rising from the chair, attempting to get up, By pushing on the arms of the chair or bouncing using several attempts, that's impaired gait as well. Patient walks with their head down. They grasp onto furniture or the support person or a walking aid, or they can't walk without assistance. So that would be about the gait. And something about this attempting to get up by pushing on the arms of the chair or by bouncing. I can tell you with my neighbor Bob, what he does is he bounces a little bit to scoot himself to the edge of the chair and position his feet right. So that might not count as attempting to get up. That's just repositioning himself. When using the scale, mental status is measured by checking their own self-assessment of their own abilities. So you ask the patient, are you able to go to the bathroom alone or do you need assistance? And if the reply is consistent with what you have on the orders, then, you know, it's scored a 0. If their response is not consistent with that, and they say, oh, no, I can get up. I have no problem with that. I don't need any help. Yeah, they do, and that's a 15. So then the score is tallied and recorded in the patient's chart. So risk level and recommended actions are identified. You look at what interventions are needed, the standard fall prevention interventions or the high-risk prevention interventions. The Morse is adjustable. It should be calibrated for each particular healthcare setting so that, for instance, acute care may be different than the nursing home, may be different than the rehab facility. In addition, the scales may be differently set differently between particular units in any given facility. So you kind of can tweak this to match what your needs are in your facility. I think that's why it's so useful. I mean, so many people use it. So no risk is 0 to 24, good basic nursing. Low risk, 25 to 50, you would implement the standard fall. And high risk, you would implement the high risk fall, and that would be anything over 51. So for outpatients on the Morse scale, I really like this because this would mean, you know, outpatient surgeries or just even going into the doctor's office. So you want to check all that's appropriate for the patient. So any one that the patient actually fits with. If they're on a stretcher, all rails are to be raised. Identify their room, stretcher chart, etc. Escort or offer wheelchair assistance to a patient who is at risk for falls. I've seen some patients in doctor's offices that, oh my, I'm so afraid they're going to fall before they even get up to the desk. If they're high risk, you don't want to place them on an exam table without one-to-one attendance. And provide non-slip footwear if they're transferring from the bed, the chair, or the wheelchair, or whatever. So these are just some fall prevention interventions that you can use in the outpatient. Toileting them. If they are not toileted regularly, then you get into those incontinent issues and the wet floor, etc. Instruct the patient to use that emergency call bell in the restroom. Some of them are afraid to pull that string because they're not sure what it is. And then also when they're in the recovery area, of course, you're going to make sure that they're visible and not left alone. And again, all these sedation patients must be monitored according to their hospital policy. You want to educate the patient who's on medications that increase their risk for fall and provide family their pamphlet on fall safety. There's another one called Stratify. This is another tool that you can use, and you fill out the scale as instructed. You use this tool in conjunction with clinical assessment and review of medications. Note that this scale may not capture the risk factors that are most important on your hospital ward, so consider your local circumstances as well. This form is really simple. Answer all 5 questions below and count the number of yes answers. And these are similar to the other questions. They're all similar. So, for instance, again, did they fall or have they fallen on the ward since admission? That's going to be a yes or a no. Are they agitated, visually impaired? Do they have frequent toileting, transfer and mobility Do they have a combined transfer and mobility score of 3 or 4? Transfer score, you choose one of those, and I'm down in the middle here. Transfer score, you want to choose one of those. And then the mobility score, choose one of those. So you're looking at, do they need major help, minor help? Are they immobile, independent with a walker or wheelchair? And then you score it. You get your high and moderate and low risk at that time. It's a very, very fast one. And then components of a risk assessment, definitely the fall history, like we said, medication review, physical exam, functional assessment, and environmental assessment. In the history, definitely want to have all of these questions answered. When you fell, what time of day was it? Were you able to get up? Do you use glasses? Do you use assistive devices? Where were you when you fell, and what were you doing? What kind of shoes were you wearing when you fell? And was there any symptoms that you had prior to the fall? Did you get dizzy? Did you trip? How did that happen? Any medical treatment received when you fell? And then also, it's very, very important to talk to any witnesses that were there during the fall, because you want to know, did they have unrecognized syncope? What's going on? Documentation of fall history is a quality indicator for fall prevention and management. Then the postural hypertension, and I'm not going to go over this because you're mostly nurses out there and you know how to tell if somebody has postural hypertension. So you want to just make sure that you check that on anybody who is at high risk for falls. Again, the symptoms are, as you see here, lightheadedness, blurred vision, headache, fatigue, weakness, syncope, or they may be totally asymptomatic. But it is good to check orthostatic blood pressures on patients that are elderly. There's a fall-focused exam. We're going to look at their eyes. We're going to look at their, check their eyes, their visual acuity, look at their orthostatic vital signs. Cardiac exam. Do they have a good rhythm and rate? Gait and balance evaluation, like I said, and then musculoskeletal examination of the back and lower extremities. And these things are what I saw that doctor do with Bob that I was so impressed. The neurologic exam, cognitive screen, sensation, proprioception. I'm going to go through this fast because we're running out of time. I want to go over this TUG. This is a test of functional ability. It involves timing a person standing up from the chair with armrests and using assistive devices if they normally use one, and then walking like 10 feet at their usual pace, turning around and returning to the chair and sitting down. A TUG time greater than or equal to 12 seconds suggests high fall risk. Well, I can tell you that Bob is high fall risk. Then there's the chair stand test. Assess the lower extremity strength, being able to stand from a chair of knee height without using their arms or legs. Again, have to use their legs. Without using their arms indicates increased fall risk, and he definitely fits in there too. Stage balance test. Stand in 4 positions with each progressively more challenging. Your feet parallel. Semi-tandem, kind of one in front of the other. And then tandem with the heel of one toe touching the toe of the other one, and stand there for 10 seconds. Single leg stand, one leg for 5 seconds. No, he doesn't fit into that either. So there's some key points to remember. Multifactorial interventions that address many predisposing factors can decrease falls by 25%. And falls are very common and have adverse consequences, but are often preventable. Also, current guidelines specify that primary care providers should screen older adults for falls and risk for falling at least once a year by asking about falls and unsteadiness when walking. Pretty common. PCP should refer patients to clinical and community resources to address modifiable risks. So many can be prevented by these various forms of exercise, individual risk factor assessment, medication review, and again, upping their vitamin D3 and calcium supplementation. The three key factors that should be addressed in everyone with risk is balance, medication, and home safety. Community programs out there, there's the CDC that has a lot of stuff about fall prevention. There's the National Council on Aging, which is NCOA, that has some information. Caregiver Action Network has information, as does Shield Healthcare Community. So you can get more information from there. Okay, then we have some references that you can definitely refer to. And we'll go on from there. Thank you very much for listening. And we'll go back to Brooke.
Great. Thank you so much, Kelly. That was a terrific presentation on such an important topic. We're just going to run through these housekeeping slides really quickly. As a reminder for those who registered as healthcare professionals, the CE credit certificates will be emailed to you within 5 to 7 days. If you don't receive your certificate within 5 to 7 days, please check your spam folder and contact us at marketing@shieldhealthcare.com so that we can look into it and assist you. If you don't mind, the next slide, please, Kelly. Great. If you enjoyed today's webinar, you can also find more educational information on Shield Healthcare's online community site. Our community site has over 2,000 articles, videos, educational and lifestyle resources, contributions from lifestyle specialists such as Erin Baker and Laura Cox, parents of children with special needs, and much more. We update the community site several times a week and encourage you to explore those resources at shieldhealthcare.com/community. You can also find there our past and upcoming webinars. Next slide, please. Great. We also have several free educational booklets available to anyone at no cost. That includes our Living Well with Incontinence, Living Well with an Ostomy, tube feeding guides, wound management guides, and guides for aging safely at home. You can find those links also on our community site. Next slide, please. Okay, great. And here's contact information if you need it. We are now going to open it up for questions. If you have a question, please type it in the question box on the right-hand side of your screen. And if we're not able to get to your question live today, we'll try to get in touch with you one-on-one to give you an answer in the days following the webinar. And again, on this slide here, we do have marketing's contact information here at Shield Healthcare and Capital Nursing Education's information, and that is the email address you'll receive your CE credit certificate from. So let's go ahead and dive into the questions. Great, we do have a lot of questions coming in. I'm just going to start right here. My mom has fallen out of bed but doesn't have other risk factors. She hit her head on the bedside table. She was asleep. Do you have any thoughts to protect her other than a bedside rail?
You know, there are alarms that you can put on the bed as well. I failed to mention those, but there are bed alarms that you can set up for your mom so that when she starts to move around too much or get close to the edge, that alarm can go off. We had a bed rail that we used for our mom because she, even though she wasn't at high risk at all, she would typically roll right out on the floor. So we put a bed rail up for her that was a very easy one to slide it forward and put it down. So you might look into the newer ones that are out there.
Okay, great. Thank you. A few other questions here. What is an SCD?
SCD, that is a sequential compression device. That's what we put on people's legs in the hospital to help to keep them from developing clots in their legs. We call them studs.
Okay, great. Why do NSAIDs increase fall risk? Is it because of underlying arthritis or independent of this?
You know, I was thinking the same thing myself, and yes, it was basically because if they're on NSAIDs, then you pretty much know that they've got some inflammatory things going on, such as arthritis. So that's why you would want to look into that and make sure that if it is arthritis, if it is, you know, whatever their problem is that makes them have to take NSAIDs, that's why you would want to look into that.
Great, thank you. We have a couple of comments that came in regarding the safety with the bed rail. I just want to read those out loud and see if you have any thoughts on this. One person suggested that for rolling out of bed, body pillows in bed or putting the person in bed in an alternate position can be helpful. There was another comment expressing concern that bed rails might be an entrapment issue. Do you have any thoughts on either of those?
You know, I would, if the person is confused to the point where that would be an issue, I think, I mean, everywhere that I've gone to see patients, you know, in my private practice, they're always using bed rails. But I like the alarm system better if the patient is cognitively able to understand that the bed rail is up there so that if you start to fall, you won't fall, and no, you're not going to, you know, climb over it. But if they aren't able to understand that, then, you know, that alarm system is really a great choice. I know with my mom, the rail was only at the upper part. She could still get out, and she could use the rail to help if she needed it. Like when she had hip surgery, she actually used the rail to help her get out of bed. But if it goes all the way down, then yeah, you can have a confused patient who could definitely fall trying to get out of there. So kind of have to assess the patient, assess the situation, and see which would work best for you. I think in that case, I like the alarm.
Okay, great, thank you. I do have a couple of comments and questions that came in related to the alarm. One here, at the hospital setting, sometimes when the alarm is activated, it's just a few seconds before the patient is on the floor. Do you have any suggestions to prevent this?
Actually, no, and that's true. By the time you hear that alarm, they're on their way down. The other thing that I would do, regardless of whether it's an alarm or whether you're actually using the bed rail, is to put a pad below them, something that's going to, you know, break the fall a little bit. And we had them in the hospital, those horrible pads that were on the floor that made it so you couldn't move the bedside table back and forth, but they served a very good purpose. I think, you know, it's a complex question, really, because it depends on the patient. If they, like I said, if they realize why that is there, why that bed rail is there, then, you know, we had no problem with it with our mom. She just didn't fall out of bed anymore. But if they don't and they want to climb over it, they're going to have to be watched more carefully. And that's hard because you're right. As soon as that alarm goes off, they're going to be on their way on the floor. So you just have to protect them the best way you can.
Great, thank you, Kelly. Question, do walkers with vertical handles offer better balance and facilitate posture and walking? How about vertical canes or walking sticks?
I'm wondering what you mean by vertical handles on a walker. Just a regular walker, they definitely help. I mean, that helps with balance, and you want to make it so that they're standing up straight instead of bending over real far in order to hold on to that walker. Walking sticks are wonderful for people who are, again, cognitively able to understand that. They do help with balance. But one thing that I really like, and I really think a lot of people should look into, is the tripod cane. That tripod cane is awesome because it actually rotates with you enough to give you a little bit of give without stumbling, kind of. So I do like that. But yes, walkers are great. Walkers, regular walkers that they're holding on to and standing up straight are a wonderful way to keep from falling. But then again, you have to make sure they understand that some of them have brakes. And if they don't set the brake, when you have a wheeled walker, if they don't set the brake before they turn around and sit on the seat, they could fall that way. And if they don't understand that, then they should have a regular walker that does not have wheels on it.
Oh, great, thank you. A quick question about insurance companies and related to falls. What is your feeling about insurance companies inspecting a home for elderly safety features or something along those lines?
You know, I think that would be very wise. But one thing that, pardon me, that is important to understand too is that A lot of the elderly have home health or PT. I would love, I mean, a PT or even home health nurses are trained to go in and look and see if everything is safe. Physical therapists and occupational therapists are really good at that as well. And they can give you that really good idea. I think it would be great if insurances would cover that because, first of all, better for the patient. Second, it's going to save them a heck of a lot of money when that patient doesn't fall and doesn't end up with that hip surgery, etc. So you're right. I think that would be a great, somebody should take that on and lobby for that with the insurances. And some might even do it, though. There's some insurance companies that are that proactive, but I don't think it's Medicare.
Great, thank you. I think we've got so many questions. We'll do what we can. I think we've got time for just one more, and then we'll do what we can to address them after the webinar. We do have a question about alcohol, which I know was mentioned early on. For the alcohol reduced risk, are you aware of a study that might prove causation or correlation?
I have, and this might be one that they could email me because I have, it's in the references as well, but I do have that reference on alcohol. It's very interesting that I would think it was the opposite, but I think they're talking about 1 to 2 drinks a day, which any doctor that I've talked to says that is perfect for them to 1 to 2 drinks a day, keeps them the anxiety down and helps them to cope with, their life the way it is. So, yeah, if they want to email me, I can get them that reference.
Great, thank you. If you joined late, you will be able to rewatch this presentation later. We did get a question about that, and we've got a lot of comments in on the presentation. Kelly saying that it's thanking you so much, and it's great information as always. So thank you everyone for taking time out of your day to join us for this presentation. Thank you, Kelly, for this outstanding information, and we hope you have a wonderful rest of your Wednesday.
Thank you so much, Brooke. We'll talk to you later.